Hello, everyone. Greetings from United Kingdom. My name is Vijay Singh. I'd like to thank the organizers for giving me this opportunity to share my thoughts on management of terrible triad. There is no disclosures related to this talk. So what is terrible triad? Terrible triad is a combination of three different injuries in an elbow. It's an elbow dislocation, which makes it unstable, a coronoid fracture, and a radial head fracture, which adds to the instability and the complexity of this injury. This was first described by Hotchkiss over 20 years ago. So what is so terrible about it? It can be an extremely unstable injury. It's relatively uncommon injury. Main problem is that there's poor understanding. Sometimes the fracture fragments are quite small, making it difficult to fix. And patients don't often do well because of the magnitude of injury, leading to articular cartilage damage, instability, stiffness, and often it's added by the poor management. So this is a classic example of a terrible triad with an unstable elbow. So what do we do? So radial head will need fixing or replacement, coronoid fix it or leave it. And then the question is whether you need to go medially. What about the MCL and the coronoid? And finally, do I need to do an external fixator? If we look at the ligaments of the elbow, on the medial side is the anterior cord, which is the most strong and the stable one. The other parts are also there, but the main one is the anterior cord. The lateral collateral ligament has got various parts to it, the anterior and the posterior limb, the annular ligament, and of course the LUCL, which is the strongest of all the ligaments around the elbow. To evaluate these injuries, apart from the patient's overall assessment, you need an anterior, posterior, and a lateral radiograph. Sometimes traction views may be useful, certainly, if not possible preoperatively, then at the time of surgery. This helps. A CT scan is almost a must to look at the size of the fragments, which will allow to make your definitive planning. This is an example of one of the patients. You can see there's lots of fragments and it's very difficult to see what is from where. You can see that the radial head is snapped off. The coronoid looks flattened. There's another piece of bone floating around here. And you can see the CT scan shows that radial head looks like a fairly large chunk. And also the coronoid looks a reasonable size, but there is some combination in there. We talk about the management. I think non-operative treatment is generally, for the sake of discussion, vast majority of the patients will require surgery. The ones who undergo non-operative may be because of the patient's whole situation, and also you need a stable elbow. The key thing is to keep a close eye and watch it like a hawk, otherwise they can become problematic. Surgical management, the principles include to restore elbow stability, protect the reconstruction, should be able to allow some early range of movement, and stability and protection take precedence over motion, as you may be able to help with the range of motion at a later date. Positioning, generally the type of injury defines what approach going to use. Most commonly, it's either a lateral or a supine position, depending on what is going to be needed. So the steps involve restoration of coronoid, restoration of the radial head, restoration of the lateral soft tissue, if required, the medial soft tissue, and then external support. Management of the coronoid depends on the size of the fragment. This is the old classification by Morey, dependent on the size of the fragment. The more useful one is O'Driscoll's classification, described nearly 20 years ago. Type 1 fracture, where this does not extend beyond the sublime tubercle, and hence the CT scan is more relevant here. In type 1, you can ignore it if the rest of the stabilization provides good fixation, or you may use suture fixation, like so in a retrograde manner, for a small fragment like this. So in this case, you can see I've done the radial head replacement, and those two suture holes are retrograde sutures that is passed into the soft tissue of the coronoid before inserting the radial head. So in this one, the patient was approached laterally. So once the radial head is removed, then it provides good access to the coronoid fragment. This is a slightly bigger fragment here of the coronoid fracture, and this one may use a screw fixation. So you can see this is a significant injury, not just the coronoid. There is an ulnar shaft fracture as well as the radial head fracture. First fix the ulnar shaft to provide stability there, and then the coronoid was fixed with a screw. Last type is the third part, where there's more than 50% of the height involved, and this in itself can cause instability of the elbow, and this needs proper planning and stabilization. So in this case, you can see the whole fragment is moving away, even on plain radiographs, and this was fixed using a special coronoid plate. Also, the medial collateral ligament was ruptured, which required repair using an anchor. Radial head fractures, we know the Mason classification, which was described nearly 70 years ago, and this still holds true. In my experience, once there are more than 3 fragments of the radial head and neck, then it becomes difficult to salvage the radial head, and I prefer to do a radial head replacement. But having said that, it depends on the size of the fragment. So in this one, you can see the radial neck is intact, and hence we managed to fix it with 3 screws, as well as repairing the lateral collateral ligament. Next patient shows a fracture of the radial neck as well. We applied the plate here, repair of the annular ligament using 2 anchors, as well as the lateral collateral ligament. If you're planning to do a radial head fixation with a plate, then you need to know the safe zone. Otherwise, the supination and pronation can be restricted. Radial head replacement is required probably in more than half of these patients. And the combination, sometimes, although the radial head and neck may be intact, but the remainder of the fragments are so mushed up that it's not possible to fix. For example, in this case, I had no other option but to excise the remainder of the radial neck and head and do a replacement, as the elbow was unstable. Important thing is to check the height of the radial head, because it's very easy to overstuff the elbow joint with the prosthesis, especially that the lateral collateral ligament is torn. It's quite easy. So there's a few things to look out for. One is the size of the radial head resection that you've undertaken. That gives an idea as to what size you will need. Second is looking at the proximal rim of the radial joint, and it's important that the radial head prosthesis stays below the coronoid, as shown here with the arrow. And lastly, looking at the ulnar humeral joint, and again, the radial head prosthesis should be below that, otherwise this will be considered as an overstuff. Always repair the lateral collateral ligament complex, and in acute cases, this should be pretty straightforward. And I generally prefer using an anchor with non-absorbable sutures. Medial collateral ligament generally is not required. I would fix it if I'm opening medially, or if I'm looking for the coronoid fixation, and then I would approach it medially between the FCU and the ECU. If you're going on the medial side, then consider doing the decompression of the ulnar nerve. If we look at the approaches, the lateral approach with the Coker's approach between the anconeus and ECU, this is safe approach. The problem is it's less extensile, and you would need to go into the Kaplan approach later on if you require an extension. Key to remember is your posterior introitious nerve, as well as the LUCL. although in most cases this is evulsed from the humeral condyle. If you're using this approach to do a radial head replacement or fixation, key to remember is the posterior interosseous nerve, which is further and safer with the forearm in pronation as compared to supination. And more parallel and more anterior keeps it safe. Medial approach, you've got two options, either lifting the whole ward of the medial common flexor origin and following the ulnar nerve, and that's what I prefer. Just to finish off, showing a couple of examples. 25-year-old young man with this fairly severe injury, which we saw earlier as well, and these are his CT scan. And you can see that in him, the radial head replacement was done. Repair on both sides, the medial as well as the ulnar side was, on the lateral side was done. And this is his movements 1 year down the line. So if you go in early, follow the principles, you will achieve a good outcome. And in here, I use both a medial and a lateral approach. So in my practice, I fix the coronoid if a large fragment or anteromedial facet is involved, fix or replace the radial head, fix the lateral soft tissue structure, fix medial if still unstable. Take-home message is to get appropriate imaging, choose the appropriate approach, plan the steps and the approach before surgery, and safeguard the nerves. Plan to mobilize early and under supervision. This is just a flow chart diagram which will help in planning. I've not needed to use the X-fix. If I'm concerned, then I prefer to put them into a brace or a range of motion brace or removal back slab, as X-fix causes its own problems. Thank you very much.